Bismillahirrahmanirrahim. Today we will talk about the management of nausea and vomiting in pregnancy and hyperemesis gravidarum in the light of Green Top Guideline number 69 2024. The guideline gives importance to the POCI score and it states that an objective and validated index of nausea and vomiting such as pregnancy unique quantification of emesis and hyperemesis level prediction tools can be used to classify the severity of NVP and HG. Ketonuria is not an indicator of dehydration and should not be used to assess its severity. There are safety and efficacy data for the first-line antiemetics such as antihistamine, phenothiazine, doxylamine, pyridoxine, and they should be prescribed initially when required for NVP and HG. There is evidence that Ondansetron is safe and effective. Its use as a second-line antiemetic should not be discouraged if the first-line antiemetics are ineffective. Women can be assured regarding a very small increase in the absolute risk of orofacial clefting with Ondansetron use in the first trimester, which should be balanced with the risk of poorly managed HG. Metoclopramide is safe and effective and can be used alone or in combination with other antiemetics. Because of the risk of extrapyramidal effect of metoclopramide, it should be used as a second line and intravenous doses should be administered by slow bolus injection over the last 3 minutes to help minimize these effects. Women should be asked about previous adverse reaction to the antiemetic therapies. If adverse reactions occur, there should be prompt cessation of the medication. Normal saline with additional potassium chloride in each bag with administration guided by daily monitoring of electrolyte is the most appropriate intravenous hydration. Combination of the different drugs should be used in women who do not respond to single antiemetics. Thiamine supplementations in the form of vitamin B complex or Pabrinix should be given to all women admitted with vomiting or severely reduced dietary intake, especially before administration of the dextrose or parenteral nutrition. All therapeutic measures should have been tried before considering termination of pregnancy. There is variation in the care of the women who have nausea and vomiting in pregnancy or hyperemesis gravidarum with the potential for lack of understanding of its severity and option for the treatment and support. Nausea and vomiting in pregnancy affects up to 90% of the pregnant women and is one of the most common indications for hospital admission among the pregnant women with a typical stay of between 3 and 4 days. Nausea and vomiting in pregnancy is defined as the symptom of nausea and vomiting during pregnancy when the onset is prior to 16 weeks of gestation and where there are no other causes. The term often used in the lay media for nausea and vomiting is morning sickness, which is usually inaccurate. Hyperemesis gravidarum is a severe form of the nausea and vomiting which affects between 0.3 to 3.6% of the pregnant women, interfering with the quality of the life and ability to eat and drink normally. Reported hyperemesis gravidarum recurrence rates vary from 15.2% in a Norwegian hospital registry study to 89% if using self-reported diagnosis. In a population-based pregnancy cohort using general practice record, the prevalence of clinically recorded nausea and vomiting in pregnancy and hyperemesis gravidarum was 9.1%. 2.1% had hospital admissions. 3.4% were treated with antiemetics in the primary care only, and 3.6% had only recorded diagnosis. Therefore, it is likely that the use of definition that puts more emphasis on the subjective patient-focused criteria will lead to an increase in reported incidence rates. The major mechanism of nausea and vomiting in pregnancy and hyperemesis gravidarum has recently been elucidated to be related to the hypersensitivity to the vomiting hormone growth differentiating factor 15, that is GDF15, which causes loss of appetite, taste aversion, nausea and vomiting, and weight loss. How are nausea and vomiting in pregnancy and hyperemesis gravidarum defined and diagnosed? So the definition is this: nausea and vomiting in pregnancy is diagnosed when the onset is prior to 16 weeks of gestation and other causes of the nausea and vomiting have been excluded. So regarding the true definition of the hyperemesis gravidarum, the guideline states that the hyperemesis gravidarum can be diagnosed when the symptoms start in the early pregnancy. Nausea and vomiting are severe enough to cause an inability to eat and drink normally and strongly limit the daily activities of living. The signs of the dehydration are contributory to the diagnosis. Clinicians should be aware of the features in the history, examination, and investigation that allow nausea and vomiting in pregnancy and hyperemesis gravidarum to be assessed for their severity to be monitored. Nausea and vomiting in pregnancy typically starts between 4th and 7th week of gestation, peaks in approximately 9th week, and resolves by the 20th week in 90% of the women. A multi-stakeholder international consensus process developed a definition for hyperemesis gravidarum to aid clinical diagnosis. The Windsor definition describes hyperemesis as the nausea and vomiting of one which is very severe beginning in the early pregnancy. The signs of dehydration are considered contributory to the diagnosis. The definition represents a shift from historic reliance on the objective measures toward the subjective patient assessment. The Rhodes Index was originally validated to measure the nausea and vomiting in chemotherapy patients, including assessment of the physical symptoms and resulting stress, but has subsequently been used for the nausea and vomiting in pregnancy. A shorter disease-specific questionnaire was developed by the Mother Risk Program and NVP Helpline in Canada. So the PUCI score put a reliance on the well-being score that correlated with the hydration status of the patient. The PUCI score can be used to determine whether the nausea and vomiting is mild, moderate, or severe. Also, this score can be used to assess the response to the treatment for mild, moderate form of the nausea and vomiting in pregnancy, but is not valid for the severe nausea and vomiting in pregnancy and hyperemesis gravidarum. The HELP score was developed and validated by the Hyperemesis Education and Research Foundation in the USA to quantify hyperemesis gravidarum symptoms into score that can be trended over time to monitor progress and response to the treatment. Nausea and vomiting in pregnancy and hyperemesis gravidarum are associated with hyponatremia, hypokalemia, low serum urea, raised hematocrit, and ketonuria with a metabolic hypochloremic alkalosis. If severe, a metabolic acidosis may develop. In 2/3 of the women with hyperemesis gravidarum, there may be abnormal thyroid function tests based on the structural similarity between thyroid stimulating hormone and hyperemesis gravidarum with a biochemical thyrotoxicosis. The liver function tests are abnormal in up to 40% of the women, and both bilirubin and amylase levels may be mildly elevated. So how to take history from a patient with hyperemesis gravidarum? We need to ask questions related to the previous history of nausea and vomiting in pregnancy and hyperemesis gravidarum. Secondly, we need to quantify the severity using PUCI or the HELP score. Moreover, ask about the self-reported nutritional status or rapid weight loss, ask about comorbidities, the relevant surgical history, and the history to exclude the other causes. In the clinical examination of such patients, we check the temperature, the heart rate, the blood pressure, the oxygen saturation, respiratory rate, the abdominal examination, the weight of the patient, sign of the dehydration, sign of the malnutrition or rapid weight loss, and the neurological signs. What investigations are advised in patients with hyperemesis gravidarum? First of all, urine analysis, because we need to check the nitrites level and the ketonuria. Secondly, MSU if dipstick indicate the signs of UTI. The other tests include urea and electrolytes, full blood count, blood glucose level, ultrasound scan, TFTs, LFTs, amylase, and VBGs. Now, how should a woman with nausea and vomiting in pregnancy and hyperemesis gravidarum be cared for? What initial clinical assessment and baseline investigations should be performed? Women with a mild nausea and vomiting pregnancy should be cared for in the community with antiemetics. Ambulatory daycare should be used when the community or the primary care measures have been failed. If the women are unable to tolerate oral antiemetics or oral fluid, then ambulatory daycare management is appropriate. Now, inpatient care should be considered if there is at least one of these criteria, like first of all, continued nausea and vomiting. Secondly, the clinical signs of dehydration and the weight loss and associated comorbidities such as UTI, inability to tolerate the oral antibiotics, and the epilepsy, diabetes, HIV, and psychiatric disorders, etc. Now, where inpatient care is required, an ultrasound scan should be scheduled to confirm the viability and gestational age and to assess for the multiple pregnancy or trophoblastic disease. Unless there are other medical reasons for urgent scan, this should be scheduled for the next available appointment. Now, we need to consider the IV rehydration in patient with hyperemesis gravidarum. And this IV rehydration can be considered at home as well. Now, women should be counseled that the benefits of antiemetics outweigh the risk and that the absolute risk is very low. Antiemetics are therefore appropriate and should be offered. If women are unable to tolerate oral antiemetics or oral fluids, then ambulatory daycare management should be considered, which provide intravenous fluid vitamins like thiamine and parenteral antiemetics. Various rehydration regimens have been shown to be effective. Now, how should women with nausea and vomiting in pregnancy and hyperemesis gravidarum be cared for? Combination of the different drugs should be used in women who do not respond to single antiemetic. A delayed release combination of doxylamine and pyridoxine, that is vitamin B6, is only licensed treatment for nausea and vomiting in pregnancy in the UK, so can be used as a first line for mild to moderate nausea and vomiting in pregnancy requiring treatment. For women with a persistent or severe hyperemesis gravidarum, the parenteral, transdermal, or rectal route may be necessary and more effective than an oral regimen. Corticosteroids should be reserved for the cases where standard therapies have been ineffective and used in combination with the antiemetics. Clinicians should use antiemetics with which they are familiar. Many women will require a combination of 2 or more antiemetics. There is no association between the degree of nausea and vomiting in pregnancy at 12 weeks and pyridoxine level measured at 15 weeks. A study demonstrated that the combination of the doxylamine and pyridoxine was significantly more effective than pyridoxine alone. Corticosteroids should not be used until conventional treatments with intravenous fluid replacement and regular antiemetics have been proven to be ineffective. The suggested dose is IV hydrocortisone is 100 mg twice daily, and once clinical improvement occur, conversion to oral prednisolone 40 to 50 mg daily is done with the gradual tapering dose. In most cases, prednisolone needs to be continued until gestational age at which hyperemesis gravidarum would have been resolved, and in some extreme cases, prednisolone is continued until birth. About ginger, the guideline says that there are no trials of community use of the ginger for severe nausea and vomiting in pregnancy and hyperemesis gravidarum. So health care professionals should not suggest it, and doing so may delay the access to effective treatment. Now we will talk about the safety of pharmacological agents used in the treatment of nausea and vomiting in pregnancy and hyperemesis gravidarum. So the first line agents include antihistamine, phenothiazine, and pyridoxine and doxylamine combinations, and they should be prescribed initially when required for the nausea and vomiting in pregnancy and hyperemesis gravidarum. The second line is that of the Ondansetron. There is evidence that Ondansetron is safe, and its use should not be discouraged if the first line antiemetics are ineffective, and women are reassured regarding the very small increased risk of the orofacial clefting with the Ondansetron use in the first trimester, which should be balanced with the risk of poorly managed hyperemesis gravidarum. The additional second line metoclopramide is safe and can be used alone or in combination with other antiemetics. The maximum dose of the metoclopramide is 30 mg in 24 hours or 0.5 mg per kg body weight in the 24 hours, and the maximum duration is about 5 days. Intravenous doses should be administered by slow IV bolus over 3 minutes time. The dystonic reactions have been shown to be significantly less common in the non-pregnant patients receiving a slow infusion as opposed to the bolus injection of 10 mg of the metoclopramide. Women should be asked about the previous adverse reaction to the antiemetics therapy. If adverse reactions occur, there should be prompt cessation of the medications. In order to prevent the adverse effect of the medication, urea and serum electrolyte levels should be checked daily in the woman requiring intravenous fluids. Secondly, histamine type 2 receptor blockers or proton pump inhibitors may be used for the woman developing gastroesophageal reflux disease, esophagitis, or gastritis. The thiamine supplementations, either oral 100 mg TDS or intravenous as a part of vitamin B complex or Pabrinex, should be given to all women admitted with the vomiting or severely reduced dietary intake, especially before administration of dextrose or parenteral nutrition. Women admitted with hyperemesis gravidarum should be offered thromboprophylaxis with a low molecular weight heparin. Those being managed in the community should be assessed for VTE risk. Graduated compression stocking should be used when the low molecular weight heparin is contraindicated. Thromboprophylaxis can be discontinued upon discharge providing no other indication exists for the continuation of the thromboprophylaxis. Women with a previous or current nausea and vomiting in pregnancy or hyperemesis gravidarum should consider avoiding iron-containing preparation if these exacerbate the symptoms, or consider alternative route for the administering of the iron. Women should be questioned about their bowel habits and offered a laxative if constipated, and particularly if ondansetron is used. Women should be offered treatment with a proton pump inhibitor for the gastroesophageal reflux disease. Wernicke encephalopathy due to vitamin B1 or thiamine deficiency classically presents with the blurring of the vision, unsteadiness and confusion, or memory problem, drowsiness, and on examination there is usually nystagmus, ophthalmoplegia, hyporeflexia. Women should be discharged once appropriate antiemetic therapy has been tolerated. Adequate oral nutrition and hydration has been tolerated, and the management of concurrent condition is complete. At the time of the discharge, it is essential that women are advised to continue with their antiemetics where appropriate, and they should know how to access the further care. Women with a severe nausea and vomiting in pregnancy or hyperemesis gravidarum who have continued symptom into late second and third trimester should be offered serial scans to monitor the fetal growth. What are the optimal rehydration regimens for ambulatory and inpatient care? Normal saline 0.9% NaCl with additional potassium chloride in each bag with administration guided by the daily monitoring of electrolytes is the most appropriate intravenous hydration. The use of the dextrose infusion for the fluid replacement in nausea and vomiting in pregnancy and hyperemesis gravidarum is not recommended. A woman's quality of the life can be adversely affected by the nausea and vomiting in pregnancy and hyperemesis gravidarum, and the practitioners should assess the severity of the woman's symptom in relation to her quality of the life and social situation. Practitioners should carry out a full assessment of the both physical and mental health status during pregnancy and refer for psychological support if necessary. The pre-existing mental health conditions may be exacerbated by the hyperemesis gravidarum, particularly where prescribed the oral medications are not being taken or kept down because of vomiting. Information about the patient support group should be provided to all women admitted with the nausea and vomiting in pregnancy. Now, what is the role of multidisciplinary team? In a woman with a severe nausea and vomiting in pregnancy or hyperemesis gravidarum, input should be sought from other allied professionals as well. Now, when should enteral and parenteral nutrition be considered? When all other medical therapies have failed to sufficiently manage symptoms, enteral tube feeding or parenteral treatment should be considered with a referral to gastroenterology and multidisciplinary team approach in parallel to the ongoing medical therapies. When should termination of the pregnancy be considered? All the therapeutic measures should have been offered before considering the termination of the pregnancy. What are the long-term effects of nausea and vomiting in pregnancy and hyperemesis gravidarum? Women who experience hyperemesis gravidarum in pregnancy are at increased risk of postnatal depression and post-traumatic stress disorder as well. Regarding the long-term effects of nausea and vomiting in pregnancy and hyperemesis gravidarum, we should also tell about the risk of the recurrence in the future pregnancies. Now, what advice should be given to the woman about the future pregnancies? First of all, we should use the early use of the lifestyle modifications for the patient. Moreover, the dietary modification is essential, and the early use of the antiemetics may help her. Now, here we have Mother Risk Pukui scoring system. The first question which is asked is that in the last 24 hours, for how long have you felt nauseated or sick to your stomach? Secondly, in the last 24 hours, have you vomited or thrown up? The third question is that in the last 24 hours, how many times have you had retching or dry heaves without bringing up anything? So based upon the answers given by the patient, we give specific score. So 6 scores indicate mild hyperemesis gravidarum, 7 to 12 moderate, and 13 to 15 scores indicate severe form of hyperemesis gravidarum. Now this chart indicates the recommended antiemetic therapies and their dosages. The first line include doxylamine and pyridoxine, the cyclizine, prochlorperazine, and chlorpromazine. The second line include metoclopramide, ondansetron. the third line include the hydrocortisone. So thank you so much. That was all about the latest 2024 Hyperemesis Gravidarum RCOG guideline. Subscribe on Obs and Gynae. Thank you so much. Allah Hafiz.